and show you, we do have a couple of questions. One second here. Okay, oops. So the first question is, do you recommend that we screen all pregnant women with a hemoglobin A1C or just those with risk factors? If it's a targeted screening, which risk factors are the most important? And what percentage of women have these risk factors, and how many have no risk factors but still develop GDM or pre-GDM? And the full question is on the screen, so I
Yeah,
need to
I'm
go.
seeing it. I think they mean, do we recommend screening all pregnant women with A1C to screen for GDM and type 2 diabetes? And yes, we do employ that at UCSD. And we do universal screening at UCSD because we have a high-risk population. We have a very obese population with a lot of ethnic minorities. And so those women are higher risk of developing both GDM and type 2 diabetes. So we do universal screening at UCSD.
Oh, sorry, I don't know what happened there, but let me get this going again. And so if it's targeted screening, the risk factor that you're seeing as the most important is the obesity?
Well, there's multiple risk factors, right? We talked about it: obesity, advanced maternal age, being part of an ethnic minority, and a family history of type 2 diabetes are all risk factors for GDM.
Okay, and then what percentage of women with these risk factors are developing GDM, and how many with GDM had no risk factors? Do you know?
That I don't know off the top of my head, but I can tell you that in certain ethnic minorities who are obese, there's a risk of about 20%. And if you look at the HAPO trial, which was like a multinational study, about 20% of women would be diagnosed with GDM. So,
Thank you. Last question. Oh, we've got one more that just came in. How is obesity defined in a preschooler?
so it's not really obesity, even though I use obesity as a term. It's actually overweight, and it's defined, if you look at different studies, as greater than 85th or greater than 90th BMI for age. So that's how they define it.
Okay, thank you. Okay, I got two more than just popped in. The first one is, can moms breastfeed during the postpartum 7-hour 75-gram OGTT?
The answer is nobody knows for sure, but yes, they can.
Okay, and let's see, can you use an A1C at the 6 weeks postpartum follow-up?
It's very controversial because if you look at a GDM patient, she's going to be under excellent, hopefully, excellent control during pregnancy because you're trying to achieve those normal glucose values, so that's going to lower your A1C. So I'm not sure that 6 weeks postpartum is enough time for the A1C to reset to baseline, and so that's why there's some criticisms with using the A1C. I use it because I think many times moms, the last time I see them is a postpartum visit. So if I have them there, I send them for a quick A1C, but I tell them they still need to have the 2-hour OGTT to be sure that we can classify her into the appropriate group. But it's helpful, but not, it can't replace the 2-hour GTT, unfortunately.
Okay, thank you. Let's see, if a mom is unable to breastfeed, what strategies would you suggest to her to prevent or reduce risk?
Weight loss. So postpartum weight retention is a major risk factor, we know, for women to develop not only obesity and metabolic syndrome, but also type 2 diabetes. So weight loss is important. So trying to set realistic goals about getting back to their pre-pregnancy weight if they were normal, or even lowering their pre-pregnancy weight if they started the pregnancy obese.
Okay, and the last one, can you diagnose pre-diabetes? Okay, maybe not the last one, I just got another one pop up. Can you diagnose pre-diabetes before 24 weeks gestation?
Yes, we have been utilizing A1C in the first trimester here at UCSD, and we are currently referring patients with prediabetes for diabetic education and counseling, and we are treating them as if they had gestational diabetes.
Okay, what do you think about using glyburide during pregnancy?
We use glyburide routinely at UCSD as well as metformin in pregnancy to control hyperglycemia and to treat GDM.
Okay. What if you're working with a population that is not high risk and you want to do targeted screening? Would you be screening on those areas that you mentioned earlier, or is there something else to look at?
No, those areas that I mentioned before, so obesity, ethnic minority, advanced maternal age, smoker, family history of type 2 diabetes. Those are the main risk factors. And the California Diabetes and Pregnancy Program has on their website the criteria for risk-based screening.
Okay, thank you. Let me see. I'm not sure about this one. Does insurance usually cover the cost of screening with an A1C? Do you know?
We haven't had a problem with insurance reimbursements for our patients.
Okay.
But obviously that varies from place to place.
Okay, thank you. Do we know the normal range of an A1C throughout a pregnancy? Can we do the test after 20 weeks?
So we don't know. I don't think that there's been a study looking longitudinal at A1Cs throughout a pregnancy to really know what the values are. And unfortunately, as you know, insulin resistance worsens in pregnancy, so that may have an effect on the A1C later in pregnancy. So that's why the American Diabetes Association recommended screening in the first trimester with an A1C and not later in the pregnancy, because early, presumably the insulin resistance is minimal compared to later on in the pregnancy.
Okay. Do you think metformin is preferable to glyburide in the first trimester?
So insulin, the use of medications for the treatment of GDM, it's its own webinar, I'm sure. And we do have evidence about the safety of metformin in the first trimester because it's been used in, mothers who have PCOS, and we know that fairly large studies have not shown that it's teratogenic or that it has long-lasting effects on the neonatal development. However, the studies aren't huge. With glyburide, there's no such data, so we generally think that metformin is safe in the first trimester, but glyburide is still, we don't use it in the first trimester, only in the third trimester.
Okay, we've got, I think, maybe 2 more minutes here. In those 2 minutes, can you speak in more detail about the peripheral insulin resistance in pregnancy?
I'm not sure exactly what they want me to mention, but I will say this. There's peripheral insulin resistance that occurs in any normal pregnancy, and that's to facilitate the transfer of glucose across the placenta to the fetus. It appears to be mediated by the placental hormones like progesterone, estrogen, and of course human placental lactogen plays a major role. But there's also liberalization of fatty acids in the mother, again, to facilitate transfer to the fetus, and that also seems to predispose to insulin resistance. But there's variation in insulin resistance among different ethnic minorities, and if you happen to be obese, etc.
Okay, thank you. I think that is all of the time that we have. You need to move on to your next meeting. Thank you so much for all of your information and your time. As always, I learned a lot today. We really do appreciate your time,